Good afternoon, everybody. We're just going to let everyone filter into the room. We're expecting a fairly large group today, which is exciting. All right. We're going to get started for sake of time. So, good afternoon, everybody. My name is Kayla Panko, and I'm the nurse educator for the Alliance for Innovation on Maternal Health Vermont team, the AIM team. And as you can tell on your screen, we will be recording today's session because we had several people reach out who couldn't make it last minute and are very interested in reviewing it after the fact. So a little context for today's training session. The Vermont AIM team, we have been in practice for the last several years and implemented bundles such as obstetric hemorrhage and hypertensive disorders in pregnancy. And our upcoming bundle, which we will, spoiler alert, have a webinar on in January, late January, will be to introduce the third official bundle, the substance use disorder bundle for pregnant and postpartum people. So one of our global topics is providing trauma-informed care, and that's under the SUD bundle. So that was one of our first areas to focus on for trainings to make available to our Vermont healthcare providers and community partners. So this is our third and final live session. We're very excited that Courtney and Alexis has joined us now for the third time, and they came to Vermont in October, all the way from Texas to present. And we had 150 people get through the first day's training between a didactic session and our Vermont A1 conference. So, like I said, we'll record this session and then through funding through VDH, the Maternal Mortality Review Panel, the MMRP, we were able to purchase some modules from Courtney and Alexis to provide more education on this really, really important topic. Today is only scratching the surface. So for those who couldn't make it or would like more, there'll be more information coming in early January. So with that, I will turn it over to Courtney and Alexis.
Awesome. Awesome. Okay. I was trying to pull up. Give me 1 second. I was trying to pull up the PowerPoint. I wasn't ready. Um, I'll do that. I'll do that here in a second. Um,
While you pull it up, I can start
okay,
introducing
perfect.
myself.
Okay.
Yeah. Well, my name's Alexis Edwards. Like Kayla said, I'm located outside of Austin, Texas. I'm a licensed clinical social worker supervisor. I'm also a certified doula, and I have a private practice here that specializes in perinatal mental health as well as trauma recovery. And then I also have 3 kiddos of my own. I have a middle schooler doing middle school things like Sigma, Rizzler, whatever. I have a neurospicy queen of the household, our middle child, and we have a 4-year-old that we affectionately call Danger Baby. So I'm busy and tired, as my picture suggests.
Love it. Well, my name is Courtney. I am in the Dallas area. I am a therapist, doula. I do some mindfulness and yoga work as well. I own a practice called Soulfully Rooted Wellness, where we primarily work in the perinatal field. I do a lot of work with those that are expecting or recently postpartum. Also, love, love, love talking about sex and intimacy during the perinatal period. I got one little nugget that I guess he's in between that we're not, he likes to talk about Ohio a lot, but we're not to the like Sigma phase, I guess, but we'll see. Anyways, so yeah, so that is me. And then this is us. Alexis and I came together. Alexis likes to say we met as baby social workers. And I don't do in early 2000s. When did I don't know. Anyways, um,
When I left, I was pregnant with my oldest, who's 12. So
12. Okay. So
somewhere before that.
somewhere before that. We met working, doing prevention education and counseling for domestic violence agency, and from there, our professional relationship as well as our personal relationship grew. Alexis was my doula for my little nug. So we've been through a lot, personally, but also professionally, developing trauma talk, which kind of started as a little, what, 1.5 hour training and then expanded to 3 hours. And now we have our 7 module training, and we're getting the opportunity to train amazing providers like you all about all things trauma related. So super excited to be here. Anything you want to add to that, our introduction
You did
before?
great.
Oh, side note, and Alexis, you guys are going to get a feel for our personalities here. When we were in Vermont in October, we did a photo shoot, just because she's in Austin, I'm in Dallas, since we're in the same place together. And we need to update this slide with our new pics.
We have some updated photos of what we look like now.
Yeah, very true. And there'll be beautiful fall foliage. We loved Vermont while we were there. So, all right. So we want to offer a trigger warning, more so of a placeholder to take care of yourself. So for the next hour and some change, we get to hang out with y'all. Of course, screens on, screens off, whatever you need to do. I got my latte here that's going to hopefully keep me alive over the next 90 minutes. So do whatever you need to do to take care of yourself. And then also feel free to ask any questions. Alexis, you can see the chat with your screen. Okay. So if you guys have any questions, feel free to type in and we can definitely pause, or we'll leave some space at the end to address any questions as well. Overall goals during our time together, we want to define trauma and also trauma-informed care and its relevance to perinatal care. I feel that a lot of people going into this training, they have their own definition of trauma and trauma-informed care, and we're just going to give one just so we're all on the same page moving forward. We hope that you'll be able to understand the unique challenges trauma survivors face during birth and postpartum. We're going to talk about several different types and categories of trauma, critically examine how existing standards of practice, procedures, and cultural norms perpetuate harm for birthing individuals, and then hoping that you will become familiar with the types of support resources and treatments available to survivors in your area. Okay, so why trauma-informed care? So even before jumping into what trauma-informed care is, we'd love to talk about why it's important. So we know that 1 in 3 women in the US have experienced rape, physical violence, and/or stalking by an intimate partner in their lifetime. And then we also know that females between the ages of 18 and 34 generally experience the highest rates of intimate partner violence. So we look at we look at that age group specifically because those are our childbearing years, give or take. And when we're looking at 1 in 3 women, that's a lot. And then kind of going from that, looking at postpartum, between 25 and 34% of women report that their births were traumatic. And 30 to 50% of trauma survivors report feeling re-traumatized during healthcare experiences, particularly during invasive procedures. And then trauma and abuse are risk factors for postpartum depression and other postpartum mental health issues, right? So if we take all these, and anytime that we're looking at stats, we have to look at them with a grain of salt because we're looking at those that reported. So I always assume that these numbers are significantly higher, but we can say that the patients and clients that we're working with, they are experiencing physical violence, stalking, rape, intimate partner violence, and they're also having traumatic birth. So our hope and goal is that we not only understand trauma, but we understand how to support clients during their perinatal period. A newer stat that we came across when looking specifically about trauma-informed care during the perinatal period, when we're looking at underlying causes of pregnancy-related deaths, the number one cause is mental health conditions. And before coming across this study with the CDC, I would have thought it was hemorrhage, especially as a doula. I know that's something that OBs and midwives alike often talk about, is their concern and fear about hemorrhage immediately following the birth. So that would have been my first guess, something in that like medical, physical realm, but definitely um, I guess I can't say surprised, but looking at that, looking at 23%, the highest on this list were related to mental health conditions, which we're going to talk about. And then before we jump into the definition, the definition of trauma that we're going to use, looking at what is trauma-informed care. So it's understanding trauma, what it is and what it is not, having responsiveness to the impact of trauma, emphasizing safety for the survivor of trauma, rebuilding a sense of control and empowerment, and then us working really hard to avoid any type of re-traumatization for the survivor.
All right, so I'm gonna dive in a little bit more around our working definition of trauma. Everything that I'm gonna kind of talk about is from a neurobiological framework. I'm a brain nerd, and that's just how I'm able to talk about these things. So if you're a fellow brain nerd, this will feel familiar, and if not, hopefully you'll learn some different resources to dive into a little bit deeper. So our working definition is that first and foremost, trauma is an emotional response to a difficult event. We're going to talk a little bit later about how oftentimes when we hear the word trauma, we're thinking of those bigger T physical or life-threatening events. But the thing about trauma is that it is really subjective. And I know from the work that Courtney and I both personally do, a lot of times what the clients are actually bringing to us is not so much what happened to them, but how they were treated through that experience. It's totally it's up to that person whether they feel that that experience was traumatic or not, and that can look really different. So for example, Courtney and I have also in our doula work, we may have left a birth like feeling really empowered and being like, yes, that went really well. But then later on when we check in with our client, they have a different perception of how things went. So we also want to be knowing that it's subjective as providers. We want to be really careful not to assume that someone felt a certain way about their experience and let them kind of lead that narrative. And then the part that I geek out about is that trauma actually rewires the brain. So the brain functions in a different way, particularly when we have complex trauma and we've experienced chronic stress. It really shifts our worldview and changes how our brain is able to work for us. So let's dive into that a little bit deeper. One researcher that I love is Dan Siegel. I don't know if anyone is, I know these online things are harder. We're very interactive. So typically we're asking like, who's familiar, seeing raised hands, so on and so forth. But if you're familiar with Dan Siegel, awesome. If not, I highly recommend looking into some of his work. But he's an interpersonal neurobiologist, and he created this hand model of the brain. So this is a really helpful way for us to look at how the brain actually rewires when we've experienced trauma. So I'm going to go through it. You're welcome to kind of practice on your own as I do it. This is a tool that we use to teach, obviously, with providers and other professionals, but this is something I even teach my clients to help them kind of understand what's happening in their brain, particularly how this is an automatic response and happens beyond their control. So this fist is going to be our brain here. Over our fingers right here are representing the highest part of the brain, or the cortex, and then the prefrontal cortex here, which is right behind your forehead. If we open it up, our palm here is representing the midbrain or the limbic system. Our thumb here is representing the amygdala, which is where that stress response originates. And then our wrist is representing the lower part of the brain, or what's known as the reptile brain or safety part of our brain. And this is where like all of our automatic function lives. It's what allows us to breathe, our heart to beat, digestion to happen, so on and so forth. The limbic system here is very emotion driven. And then this higher part of our brain, or the learning brain or the thinking brain, is where all of our executive function lives. So it's what allows us to problem solve, to feel rational thoughts, to communicate. And so it's really, really important. So what Dan Siegel talks about is this concept of I flipped my lid. So this is kind of a visual representation of what's happening in the brain when we flip our lid or when we're in a stress response. So it means that this higher part of our brain, this thinking brain, has gone offline. It's very much under functioning. We don't have access to all of those executive skills that are really necessary. And then this mid part of our brain and our lowest part of our brain, or the brainstem, are really overworking. So emotions are high, and our brain's first priority is safety. So it's going to do whatever it needs to get to safety. So this is what we know as the fight, flight, freeze responses, which we're going to talk about a little bit more later as well. But again, I love this visual because it's helpful to kind of see that this, again, this is an automatic process. Our nervous system automatically responds in this way. It prioritizes safety, and our thinking brain and all of those coping skills and things that may feel helpful in stressful times don't feel as accessible. And so it can help relieve some of that shame or guilt for trauma survivors, that like, this is happening beyond your control to protect you. That doesn't mean that we don't have the ability to bring that thinking brain back online. We absolutely can do that. And that's a lot of the work that Courtney and I do with some of our trauma therapy. But yeah, so definitely look up Dan Siegel. You can even watch a quick video if you Google him, where he kind of demonstrates the hand model of the brain. So let's keep going. So another theory that I'm a big fan of is polyvagal theory. This was created by Dr. Porges. Also Deb Dana, who's another social worker, she does a lot of work around polyvagal theory as well. So Porges and Deb Dana are both two resources if you want to read more about this. But polyvagal theory kind of combines those two terms of poly and vagal, poly meaning many, and then vagal is referencing the vagus nerve. The vagus nerve is the longest nerve in our body, so it does go from the brain stem, or that lowest part of our brain, all the way down to our gut. It's connected to all of our vital organs, and it's what's sending messages to our vital organs on what to do when we perceive danger. So it's what's kind of initiating some of those fight flight responses for mobilization or immobilization, which we're going to talk about. And what I really like about polyvagal theory is that it really kind of reworked our understanding of how the stress response works. And so I know, like, when I was in grad school, I actually was only learned about fight, flight, freeze was a response that was added later on. And then now, even beyond that, Porges talks about this first line of defense known as the social engagement system. So let's talk about that a little bit more. So he refers to our stress response as a hierarchy of defense, and he kind of describes that our brain and body moves through this hierarchy, and when one fails, we have to move to the next one. So like I said, the very first line of defense that we have, that was not something that I learned in grad school and wasn't something that I learned until later on in my career, is that social engagement system. It's a part of our ventral vagal state, which is in the parasympathetic nervous system. And it literally refers to when we sense danger, the very first thing we do is look to connect. We look to our people, to our support. And so I find it interesting too that it's referred to as a first line of defense, because oftentimes in our work as doulas, I know that's a phrase that we use for ourselves. And I think that way of most professionals in the perinatal field, whether you're an OB-GYN, a midwife, a doula, a lactation consultant. A lot of times you may be the first person within this person's care, AKA their first line of defense. And so if they're perceiving danger in any type of procedure or intervention, you're going to have an opportunity to notice the social engagement in action. And you're going to have an opportunity to respond in a way that prevents them from jumping down that hierarchy into other lines of defense. So this is like optimal arousal, we're calm, digestion is going, and we're connected and we feel safe. So if that fails, if we aren't able to make that connection, Porges talks about that, then the next line of defense is what we know as fight or flight. So this is happening in the sympathetic part of our nervous system. And this is where we're either fighting our way to safety or we're fleeing our way to safety. So we're mobilizing. So increased heart rate, heightened alertness, we're ready. Our body is getting ready. The vagus nerve is sending all of the information to those vital organs to get ready to move and leave that space or fight their way through that space to get to safety. If that fails, if we're not able to mobilize, then Porges talks about we have this one final last-ditch effort of defense known as the dorsal vagal state. This is back in the parasympathetic part of our nervous system, and it literally triggers immobilization or what we know as the freeze response. It's literally like whole system shutdown. So that vagus nerve is now communicating to our vital organs that it's time to slow down. And there is also research that when we're in this state that there's things that are, prevent us from feeling pain. It allows us to dissociate and kind of have this out of body experience so that we can kind of feel numb to what's happening to us. So this final line of defense is like, well, actually, this visual explains that better. Thank you, Courtney. So Deb Dana created, Porges talks about these lines of defense with a stoplight. So we also use that visual sometimes where it's like red light, yellow light, green light. But I like this ladder better. So Deb Dana uses this ladder where it kind of shows a visual of we can kind of move up and down through these states. But it also is a good visual of that if we get all the way down to that dorsal vagal, that final line of defense where we're completely shut down, it's going to be a lot harder for us to climb back up that ladder to a safe space, right? To feeling connected and safe and socially engaged, right? So that's why I think this model is really helpful for us as providers, is because, again, we have this huge opportunity to really be attuned to our patients and our clients and really notice when they're trying to make those connections, because then we're able to maintain safety, prevent re-traumatization, and prevent them from moving down into these different states. And the other part about that, specific to the perinatal period, is that if we have a patient that's in fight or flight or even shut down, it's also going to impact just the physiological process of birth and postpartum. It's going to impact all of those things, attachment, so on and so forth. So I like this visual. Again, this is adapted from Deb Dana.
I was
You're
muted.
muted. You're
Got
muted.
it. So looking at types of trauma, and I think Alexis had mentioned two different types of trauma. So often when people think about trauma or traumatic situation, they're thinking of big T trauma, so major trauma. So we're looking at sexual assault, childhood abuse, any type of serious accidents, including natural disasters, combat exposure for those in the military. So kind of those like big things that like I would say 99.9% of people would be like, yeah, that's traumatic. Um, but it's also important for us to look at and keep in mind that there are traumas that are considered little t traumas, and the big and the little don't mean that one is bigger or worse or whatever than the other. That little t traumas are often more commu help me, cumulative.
Cumulative.
Cumulative. Why can I not say that? And we're looking at like microaggressions, right? We're looking at discrimination. We're looking at relationship conflict. So it can be a breakup. For some people, it could be a divorce. That might be a big T trauma. It could be loss, right? And whether that's real or perceived loss. So people often don't think of, my child turning 18 and moving out and going to college as a trauma, but it definitely could be. Emotional neglect, chronic stress, anxiety, the loss of a pet, any of those things that and if we go back to that definition of trauma that Alexis looked at, that it's subjective. So I know we're going to talk, we're going to spend a good chunk of time talking about race-based trauma. And that's where that discrimination or those microaggressions or the little statements that are made that could be, easily dismissed by some people. That's when we get into that commu, commu,
Cumulative. I was
thank you, that type of trauma.
I was gonna add, like I said earlier, a lot of times these big T events also have smaller traumatic experiences within them. So for example, sexual assault, of course, that actual event typically is gonna feel traumatic and create a post-traumatic stress response. But again, how is that person treated through that experience? So we know that typically sexual assault survivors are not believed, they're victim blamed, right? So the things that people may say, how they're treated, the questions that they're asked, all of that, again, is oftentimes more of what Courtney and I see in our practice when we're working with folks, is that's where people feel stuck. And that's where they still need help kind of moving through and metabolizing that trauma, is how they were treated through that process. Do you want me to take this one?
Yeah.
Okay. So this is, we clearly like visuals. We all learn in different ways. So this is kind of a visual of these big T versus little t experiences. This is more specific to birth and postpartum. This is from Birth Monopoly, which is another great resource if you're wanting to dive in a little bit deeper, specifically around birth trauma. But this triangle kind of shows, you can see at the top of the triangle are these big T events that we're talking about. So specific to birth trauma, you can see forced procedures, use of physical force, coercion, not asking for consent before doing an intervention or procedure, right? These are big T. They're considered assault. They've caused physical harm, right? Then we kind of move down. As we move down, we're moving into degradation. So bullying, intimidation, making threats, mocking pain or suffering, disregarding birth plans, or even disregarding support people in the room, ignoring questions, not listening, and then really pressuring for certain interventions without, collaborating with the patient around their care. So this kind of starts to move into, it's still causing harm, but it's moving into more of that emotional harm, more of that smaller T type experiences that aren't often as acknowledged, right, as those more blatant physical causes of harm. And then at the very bottom is what we have as normalization, which I kind of mentioned in the sexual assault world. We very much normalize sexual assault. And so the messages around rape culture that exist really kind of perpetuate and don't hold perpetrators accountable. Same thing with birth trauma here, right? So when we move into that normalization phase, you can see like making jokes about birth plans, languages around allowing or letting that person do something versus, again, that collaborative, inclusive language, pathologizing pregnancy or birth, making jokes about pain. And then at the very, very bottom is kind of that general message that I think a lot of our clients receive in the perinatal period of like, all that matters is a healthy baby, which is actually quite dehumanizing and only focuses on the baby and doesn't focus on that birthing person and them being a human and their whole experience and their needs, wants, desires, right? So when we use language like that, when we talk about like all that matters is a healthy baby, it really does kind of normalize a culture of these things that happen to you don't matter. The only thing that matters is that you have your baby, right? And that may seem really small, but it is contributing to these bigger T type experiences.
Yeah. Now, we like the quote over here, tolerance of the behaviors at the bottom supports and excuses the behaviors at the top, right? So, yeah, when we go back to that normalization of the things on the bottom and how they're kind of glanced over, we have to make changes starting there. So then we can make bigger changes of the things that are at the top. Okay, so we're going to move into talking about specific trauma. It's just your slide and my slide.
I think it's yours, but I can keep
Okay.
going.
No, I'll go. So domestic violence. Domestic violence is a pattern of abusive behavior in any relationship, when one partner is trying to gain, or maintain power and control over the other. So within that, that can be physical, typically what we think of mental, emotional, sexual, but then financial, but then and then also using technology. And I know I started working in the DV field in 2007. And it's interesting and mind blowing to just think about how technology's changed over the past whole bunch of years, when it comes to monitoring partners. So this is a power and control wheel. My brain's not working today. Originally created by the people in Minnesota.
Duluth, the Duluth
Duluth,
Mall.
the Duluth model. See, at least I knew where they're from. So there is a general power and control wheel that you're welcome to research. But this is one that was adapted, a safe passage, adapted the original power and control wheel from the Duluth model to create one that's specifically about abuse in the childbearing year. So one thing that we're going to go through some of these spokes, but we want to acknowledge that this wheel is very heteronormative, where it talks about woman abuse and it uses the perpetrator in more of like a male language. So we want to acknowledge that abuse can happen in heterosexual relationships where a male is abusing a woman, but also women abuse men, and then also in same-sex relationships as well. So we like to just put that caveat out here as we are talking about this graphic in particular. And then it's important to note that often abuse can escalate during pregnancy. And then, so these tactics specifically are used during the perinatal period. So I'll start reading some of them. I'll start with emotional abuse. So with emotional abuse, it could be telling the birthing person that she's fat, or making any other derogatory, I was worried that my lips weren't going to work for that one, derogatory comments about their changing body, being verbally abusive, so she's not able to care for herself during pregnancy and postpartum. It could be sabotaging any efforts to eliminate substances, right, to live a healthier lifestyle for her and her developing baby. It could be using children, so the child that she is pregnant with, or also any other children, so threatening harm to the child if she decides to leave, trying to convince others that the birthing person is unfit, also threatening to call child protective services. Physical abuse, increased severity or frequency of physical assaults. Often, if there is physical abuse, that abuse can be directed towards the abdomen or the genitals, often in places that many people won't see. So that could also be upper thighs. And it could be forcing her or not allowing her to breastfeed. So remember, when we're talking about domestic violence, we're talking about that power and control. So the abusive partner trying to control how the birthing person or how their partner parents or shows up for themselves or for the child or children. Minimizing, denying, or blaming. So making her solely responsible for the pregnancy and being solely responsible for all of the prenatal care, the shopping, kind of doing everything to prepare. It could also be refusing to admit that they are the father or the other parent of the child, blaming her for the child being the wrong sex. That's often um, I've heard that before, both as my work at a domestic violence agency and as a therapist, where the abusive partner, in all the situations for me, it was a male partner was blaming the mom for the baby being the wrong sex. And all I could think to myself was, they don't understand how biology works. But thinking
That's also a part of in different cultures that can be a norm that like boys versus girls are more accepted,
yeah,
right?
yeah.
Mhm.
Sexual abuse, forcing or causing unwanted pregnancy. So that could be direct means, so sexual assault, or indirect means, so refusing to use any type of protection or contraception, or tampering with any contraceptive means. Forcing to engage in unwanted sexual activities during pregnancy or too soon postpartum before the birthing person is ready or even cleared by medical professionals, which could cause injury. It could be having an affair, sexually transmitted infections, causing risk to the birthing person, but also the fetus. And then coercion and threats kind of going along with the emotional abuse piece. Threatening to leave if she does or does not have the child. That's not my baby. I'm not going to stay with you if you do have the child. Or if you decide to terminate the pregnancy, then I'll leave. Threatening to harm if she tells any caregivers about the abuse, and then threatening to cause injury to unborn baby could also be a part of that coercion, threats, and emotional abuse. I got
I can
excited and
take
kept
over.
going. Yes,
Yeah,
yes.
I can take over. So financial abuse can include denying access to adequate food to support a healthy pregnancy, making the birthing person work despite concerns for their health. So maybe they've been put on bed rest, or just simply told that they need to take it easy, and that's ignored by their partner. Refusing to pay for child-related expenses or pregnancy-related expenses, like even just buying maternity clothes or prenatal vitamins, so on and so forth. Intimidation. So this oftentimes the intimidation is essentially like threatening physical harm, right? So making threatening motions towards the birthing person. Again, those may be directed towards the abdomen or the genitalia, throwing things at the birthing person or near them, near their pregnant body, or even near the baby postpartum, or even like refusing to pass the baby to the birthing person postpartum. So maybe they're in the postpartum period and the abuser is, holding on to the baby and refusing to give the baby back, or they're snatching the baby from the birthing person's arms, so on and so forth. Isolation. So a lot of times when there's intimate partner violence in a relationship, that person is very isolated from their supports. So specific to the perinatal period, that could look like preventing that person from receiving prenatal care. They miss a lot of appointments, maybe refusing to take them. There's only one vehicle in the household, so on and so forth. Preventing them from accessing any information regarding pregnancy, not allowing them access to the library or the bookstore to buy new books, or access to the internet to research different things, right? And then refusing or interfering with any contact with family, friends. And then this can also include their care team. So limiting a choice in a provider, limiting choice in choice or even access to a doula, to a midwife, maybe forcing them to seek only a certain type of provider, right? And again, maybe even limiting access to those appointments that they really need for a healthy pregnancy and a healthy birth. And then the last category is male privilege. So demanding that she care entirely for the infant in the household, asserting that the child will be raised according to their customs or beliefs, and demeaning their role as a mother. So really kind of those typical gender roles where maybe that partner is not really supportive of any baby care, or even allowing the birthing person to prioritize their own care because they need to take care of the house and the baby, and their partner, right? And there's not a lot of space for meeting their needs. So again, this is just an example of what some of those behaviors can look like. Of course, this isn't all inclusive. And at the root of any type of intimate partner violence, which is why power and control is at the center of that wheel, is gaining or maintaining that power and control. And there's a lot of different ways that someone can do that in a relationship.
I thought of another one that was on here, super small example, but under financial abuse, you mentioned it, it says on here making the birthing person work, but it also made me think about not allowing the birthing person to work, right? If they wanted to bring in, their own financial income. So I thought about that as well. That was something I saw a lot when working for a domestic violence agency. Um, Looking at sexual violence, so sexual assault, definition, any type of sexual contact or behavior that occurs without explicit consent. So knowing that consent is permission that's freely granted. So impact on perinatal care, thinking about routine procedures that can re-traumatize survivors. And this can lead to fear of medical providers, anxiety, disassociation during labor, or even reluctance to engage in prenatal care for the fear of being re-traumatized. Clinical
Relevance.
elements. So creating a safe and respectful environment, being able to take the time to explain procedures. I'm coming in, this is who I am, and then this is what's going to happen, this is what we want to do. Being able to obtain consent for that plan at every step, and then providing space for patients to ask questions, but then also express any type of concerns. So knowing that all trauma, but especially sexual trauma, can have a huge impact on the clinical care that is being provided. So, thinking about trauma sensitive pelvic exams, thinking about the experiences during labor and during delivery, which we're going to talk some more about.
Yeah, I usually like to share here about my own personal OB-GYN, as far as like what a trauma sensitive pelvic exam looks like to me. I do know our time in Vermont, we did learn that a lot of you guys are really ahead of the curve with this being more of a standard of practice. In Texas, unfortunately, that's not Courtney and I's experience, and we know that that is true in lots of other spaces in the US, that there's still work to be done here. But what my doctor offered is, she brought out a tray of different speculums and she's like, here's the options. This one's a little bit smaller. You can kind of choose which size you want to use. She offered for me to insert my own speculum. She offered for me to use stirrups or not use stirrups. We really kind of talked through, ahead of time before I even was like nude and on the table, which that was actually a first step, is like I asked to talk to her before, because a lot of times you can show up to an appointment and the nurse is kind of like, here's the gown, get on the table. And then you're talking to the doctor when you're sitting on crinkly paper with no pants. And it's quite uncomfortable and it doesn't really like invite safety from the get-go, right? So she came in while I was still fully clothed and we had this conversation before I even took my clothes off, right? So, but she explained, here's all the different steps with the exam. You can do some of it, you can do all of it, you can change your mind in the middle, right? And so we also kind of created a signal for if I wanted to stop. And then once we got to the exam, it was everything that Courtney said, where, she's like, I have my hand here. This is the next thing I'm doing. Are you still okay with this? Right? So there was that conversation the whole entire time. So just thinking about that and thinking about what exists for you already in your practice and what are some changes that you could make to create an even more trauma insensitive experience.
Forgot I was still muted. I was saying that I've heard that story lots of times during our trainings, and every single time, including today, I still get chills, right? To think about just that care that's provided and, potentially maybe more work for the provider, but provider's willingness to go that far to create a safe environment. So I think that's super cool. Moving on to where I kind of geek out and nerd out, but talking about racial disparities in birth and postpartum. So we know that Black women are most at risk for poor maternal health outcomes. So I think we've probably all heard the stats that Black women in the United States are 4 times more likely to die from pregnancy-related causes compared to white women, and are twice as likely to suffer from life-threatening complications during pregnancy and childbirth. So looking at why and trying our best to understand the trauma. So, again, thinking about the components of trauma informed care is understanding the trauma, and especially when it comes to race based trauma, understanding the history. So college educated Black mothers are more likely to experience severe complications compared to white women without a high school diploma. And research shows that this applies to Black women across all education levels and persists even after controlling for differences in social economic status. So it's not an education thing, it's not a money thing. So poverty and access to care don't tell us the whole story. I think it's easy for people to say, well, these Black mothers are uneducated, or they, aren't accessing proper care. But that's not the case, especially when we look at, more high profile cases that have gotten more media attention, like Serena Williams, and the care or lack of care that she received during her birth. So looking at systematic racism, moving too quick, systematic racism in healthcare. So first looking at implicit bias. So in 2017, there was a study done by the University of Virginia where there were OBs, residents, and other students that were studied, and they were given two patients. And the patients had the exact same symptoms. The only thing that was different was that one patient was white and one patient was Black. And what this recent study found is that the white patient was overprescribed pain medication, and that the Black patient was underprescribed pain medication. When the researchers dove a little bit more into that, what they found was that the providers had some core beliefs that were actually taught while they were in school in regards to Black people having a higher pain tolerance, having thicker skin, that their blood clots differently. And we actually, in our longer training, we also talk about a nursing text, a recent nursing text that talks about how different groups of people based on race, but also based on faith, how they have different biological needs, and just the blanket statements and these blanket expectations based on someone's skin color or their religious preferences. It's dangerous, right? To be able to say, I'm going to provide care solely based on the color of your skin. It's terrifying as a Black woman. So um, through research, what we also know is that Black women often experience racial bias. So this leads to concerns being minimized, being dismissed. And I can say, even talk about that personally in my experiences, even in the perinatal period for me. Symptoms don't feel like they're being taken seriously, which can delay life saving interventions, complications when we're looking at birth. So I think it's important, and I know that some places often offer implicit bias training, but it's important for all people to examine what their biases are, and then how that's impacting the care that we provide for our patients and our clients. Looking at chronic stress. So with the chronic stress, there's something called the increased allostatic load, specifically for Black women. So the cumulative effect of systematic racism, discrimination, and even looking at and thinking about those microaggressions create chronic stress for Black women. This stress can increase what is known as the allostatic load, which refers to the wear and tear on Black bodies. So, this prolonged exposure to this chronic stress, the discrimination, the overt aggressions, but also microaggressions, impact this allostatic load, which then is associated with adverse health outcomes. So, looking at and I've read as a doula and doing some research that Black women typically, especially during pregnancy, have higher rates of hypertension, preeclampsia, preterm birth, cardiovascular disease, and like trying to understand why it all came together for me when I found research and read a few articles about the allostatic load. So, this exposure, prolonged exposure to this chronic stress, is what's causing these higher rates of hypertension and preterm birth in Black women and Black babies. And then also, kind of along with that, a term called weathering. So this theory suggests that Black women experience accelerated biological aging, again due to this chronic exposure to chronic stress due to racism. So as a result, they're more likely to experience pregnancy-related complications at earlier ages. So again, if we're making assumptions based on this initial information that we have, so it's a Black woman and she's 28, right? And that if we're looking at, the age and the race and kind of we're making assumptions based on that, when we're looking at this theory of weathering, that due to the exposure of chronic stress, is this woman's body operating as a 28-year-old, or due to accelerated biological aging, is her body operating more at 32, 35? And then how does that then impact her pregnancy, labor, and also birth?
Courtney,
Yes.
I just wanted to read the comment that came in the
Yeah.
chat. That gives me goosebumps as a Black woman, not in a good way. So I just wanted to acknowledge that comment.
Yeah, thanks for sharing that. I think it's this is the part I said like I geek out about, and the part that's most important for me, not only to share the information, but I mean, there's definitely, personal connections to this work. One story, I don't know that I've shared during any of our time working with the providers in Vermont, but my birth story, Alexis was there, and definitely grateful for that. But my provider, I went with two midwives, both white. And I went in trusting them and feeling fully seen, fully heard, felt very confident in their care. Um, and during my birth, I had my beautiful birth affirmations that were being put up around the room. And my favorite birth affirmation was Black Girl Magic. Um, and as it was being placed, I will not forget, as I'm laboring, and I'm sure I was rocking it like 6, 7 centimeters, like knee deep in the throes of it. And I will never forget hearing my midwife say, Black girl magic. Well, what about white girl magic? And not the time, not the space, right? But also, like, what does that have to do with anything that's related to what I'm doing and the greatness and beauty and magic that I'm creating as I'm giving birth to this baby, right? And that had an impact on, my labor, but also in the moment, because I'm laboring, I can't focus, I can't process. But definitely something that when I think about my birth experience, although it was wonderful and amazing and great, that is something that sticks out. So as Alexis mentioned, those small little t things are often related to how you're treated, right? And that impacted the trust that I had with that midwife through my postpartum care as well. Um, Sorry, that was a tangent. But also looking at thinking about history, right? Again, understanding the trauma of using and abusing Black bodies in the US. So we think about slavery, we think about segregation, we think about forced sterilization, we think about medical experimentation and limited access to healthcare for Black bodies in general, but especially Black women. Um, when we think about those higher rates that I mentioned of underlying health conditions, so the hypertension, the diabetes, the obesity, again, going back to that systematic racism piece. And then the delayed diagnosis and treatment. So not receiving a timely diagnosis, having symptoms be dismissed, having symptoms be overlooked, or not receiving treatment, due to the biases in their symptoms and how they're interpreted by providers. I know something during our time in Vermont, something that came up for me and hit me hard were the high number of with Vermont having a high number of high immigrant population, that patients not feeling comfortable coming to the hospital or coming to receive medical care often until things have accelerated, or it's too late, right? And again, that speaks to that mistrust to the healthcare system, but also healthcare providers. And I know that I'm also one of those people that I'm going to try all the things for both me and my family before I even think about, going to the doctor, because it doesn't always feel like a safe space for me or for my family. So again, things for us to think about, things for us to know, that are true, that are things that have happened not only in the history of the U.S. and Black bodies, but things that are going on now, and just being aware and empathetic to how this impacts the clients and the patients that we're working with. And then looking at LGBTQIA plus communities, so knowing that the perinatal period is extremely cis and heteronormative, so also finding it important to be inclusive. So members of the LGBTQIA plus communities often face negative experiences within healthcare. So whether that's their identity being ignored or disrespected, going along with those microaggressions, so being misnamed or misgendered, also making assumptions. So for us as trauma-informed providers, wanting to know that language, remembering that language matters. So are we using perinatal, which we use often, versus maternal or maternity? Also thinking about language such as breastfeeding and chest feeding. And thinking about, are we assuming that there's a dad, or are we talking about partner? So I think being very aware of language. I often like to ask my patients and clients, both as a therapist and a doula, what they prefer, and I kind of go off of what they use, and what they call different body parts, what they call their partner, and kind of navigate from there. Having respect for family structures, thinking about the dynamics and roles of each family and how those may differ and not look like the norm, and just wanting to again be respectful, ask questions if we don't know, be curious. And then also thinking about biological considerations and medical needs. So if we're looking at hormones, we're looking at history, medical history, thinking about history of miscarriages, and how all of those things go into these individuals and families reaching out for support and being within your care. So one of my favorite kind of ideals or slides within all of this is knowing that not all medical professionals are racist and sexist, right? But we're all human beings, and all human beings have bias. So knowing that bias can have a tangible impact on treatment, so it's up to us to do the work, right? To understand what our biases are and to have a good grasp on how these biases impact the treatment that we provide, and then do the work, right? Because like this is all of us. We all have biases, and we all have to ensure that we're doing the work in order to be trauma informed and in order to provide the best possible care for our patients.
I'm noticing the time. We have 30 minutes.
What? Okay.
Yeah.
All right, y'all buckle up.
Well, I'm just wondering if some of these, if we could kind of skip ahead a little bit, but I'll acknowledge these, but I won't like
Okay.
spend a lot of time on them, right?
Okay.
So other types of trauma that are specific to the perinatal period, of course, perinatal loss, miscarriage, stillbirth, neonatal death, or abortion and termination for medical reasons. And then birth-related trauma, which we've talked about, and remembering, kind of that key thing that trauma can occur even if the birth is medically routine. So even if we feel like everything went well, it's based on that person's emotional experience of the event. Again, trauma is subjective, and it's not just about that clinical outcome. Some other mental health impacts to consider. We do know that birth trauma significantly increases the risk for PMADs, or perinatal mood and anxiety disorders. We know that 1 in 5 experience a PMAD, and we know that research shows that PMAD symptoms, they're not going to resolve without treatment. We also know that overdose and suicide are top causes of death. So that 23% that Courtney mentioned, oftentimes this isn't a part of that category. And then thinking about that, knowing that overdose is one of the leading causes, is it's important for us to think about and talk about perinatal substance use. So as far as prevalence and risks, we know that substance use, particularly opioid use, has been rising in the US. We know as far as impact for the birthing person and the fetus, infants face risks like, I never know if this is NAS or NOS. Look, we're clearly not medical professionals. Low birth rate, long-term developmental issues. We also know that for the birthing parent, they're at a higher risk for maternal morbidity, for other mental health diagnoses, and then relapse in the postpartum period. And then thinking about the different type of interventions that exist, we did learn while we were there that Vermont is actually, again, ahead of the curve, where in Texas, we're not generally ahead of the curve on many things. So it's always surprising when we learn that about other places. But making sure that your practice is using screening tools for substance use, that medication-assisted treatment is being offered, that there's a multidisciplinary approach that's not only involving doctors, addiction specialists, therapists, so on and so forth, so that there can be collaborative care. And then, again, one of those things specifically that we learned was that Vermont is taking a non-punitive approach, so that medication-assisted treatment, I actually, my brain's not working to remember it. I might say it incorrectly, so ask Kayla or somebody to back me up. But I know in Texas, that's not a treatment that's offered in pregnancy. But in Vermont, they were saying that it actually like moves you higher up the list or something. Like if they know that you're pregnant, they're gonna make sure that you receive that intervention before others. So that was very enlightening and like, whoa, that's so cool. Again, oh, that's correct. Yay. Okay. I said it right. So anyways, it was just, it was hopeful to hear that other states are doing things differently.
Correctly. Better.
Yeah. So next we're going to talk about triggers in birth and postpartum. Typically in our longer training, again, we like to be really interactive. So this is an exercise that we do with the group to kind of identify what are some common triggers in this time period. We use this word map, so you can see that those larger words are responses that were inputted more than once. So those are more highlighted, right? So I'll read a couple of them, but tearing, touch, breastfeeding, nipple stimulation, vaginal exam, smells, light, yelling, having a male care provider, right? Again, similar to trauma being subjective, triggers are going to look different for everybody. So what may trigger someone else could look different for another person. So this is something that we encourage, including in your practice, is starting to have some of those conversations around what even triggers are, what that means, why it's important to talk about it with your client or patient, and what can we do to kind of add that into maybe your birth preferences and your conversations with your care team to help minimize these experiences in your birth and postpartum, so that you're less likely to have that stress response and then kind of move through that hierarchy of defense, which, as we've said multiple times, is really going to impact that physiological process of birth, postpartum, attachment, so on and so forth.
And super quick note, it makes me think about even non-traditional triggers where I had a client highly educated, not that that matters, but also highly aware of her trauma and her triggers. And the two things as her doula that I was in charge of being the keeping her space safe was her two non-negotiables that were triggers were the smell of lavender and yellow Gatorade, right? So definitely non-traditional compared to, breastfeeding and vaginal exams, but maybe in line with the smells. Is that where those were two things that were huge triggers for her? And I was so thankful that she, expressed that to me and that I could do the work to keep that out of her birthing space. So.
So this is a quote from Dr. Porges, who's the polyvagal guy. Several features in the medical environment trigger a neuroception of defense. For example, medical environments often remove access to the moderating social support features that we have in our normal everyday life. Our clothing is taken away from us, we're put into a public place, and predictability is gone. Many of the features that our nervous system uses to self-regulate and to feel safe are disrupted. So again, doing our work through a trauma-informed lens is really going to prioritize that safety and connection. So let's move into putting trauma-informed care into practice. We had the opportunity to work with Kayla and her team to create badge buddies. I don't know if those are still available. I think she talks about that at the end. But it was really cool. They are, yay. Okay, so reach out to Kayla and her team if you'd like a badge buddy. It has this information on it. So we created these 3 C's as like a really concise way to kind of think about what does my responsiveness need to look like to have a trauma-informed practice, right? So the first C is consent. So as we've discussed, making sure consent is permission that's freely granted, no coercion, making sure that consent is continuous. So a lot of times in our work as doulas too, we see like consent signs get signed, and that's kind of the end. Consent is a conversation, it's not a signature, right? So we need to be having conversations about consent and continuously creating space for that to happen. Again, connection, so that social engagement piece, making sure that we are connecting with our clients and patients, that we're using empathy, that we're being compassionate, that we're being collaborative, and that we're really valuing their input and making sure that they feel seen, heard, and acknowledged throughout the process. And then co-regulation. So thinking about that hand model of the brain, when we're in a flipped lid state, as human beings, we do borrow from each other's nervous system. So if you're in a space, you're sharing space with someone who's here and their lid is flipped, it's going to be really easy for you to meet that energy, right? So thinking about that if you can come in fully regulated, calm, empathic, connective, the impact that that's going to have for your patient that might be here, right? And how that's going to help them move up that ladder to that safety, to that social engagement. So co-regulation is really, really important. And particularly around that piece, we love this quote, "It's not what you know that heals, it's who you are." Is the responsibility that we have as helping professionals to make sure that we're taking care of ourselves, right? Because we all have bad days, we're all tired, we might not be our best self when we show up to work that day, but thinking about how when we don't take care of our own needs, both physical and emotional, how that can impact care, how that can impact co-regulation, right? So what are your self-care practices? What do those look like? And that's a whole nother training Courtney and I offer is, kind of that radical self-care piece for helping professionals and what that can look like, particularly when there's a high rate of secondary trauma in these spaces. And then when we mention the triggers, what that conversation can look like with your clients or patients is just remembering that triggers are typically sensory. So sight, sound, smells, touch, and you can really shift a survivor's experience if we're sensitive and mindful of what those triggers may be, and how we can work to limit that in the birthing or postpartum space.
Maybe
What's
just something
after?
that can.
Oh, okay. Uh,
So I
I
was just
don't
gonna say maybe just something to consider. So we're gonna give y'all some homework. Um,
know.
so we think it's important to be able to, and I think this can be dependent on the role that you play. Because I know there's a variety of practitioners that are on the call, but thinking about if a patient does disclose past or current trauma, thinking about, and I think having some conversation with colleagues, with partners, with anyone that you may supervise or that you're providing training to, is how do you respond? How do you respond in a trauma informed way? Um, and how do we navigate that? Automatically, I think about as a doula when I'm in the room and I'm hearing a nurse go through the questions upon an intake with a client. And, what would that look like in this kind of quick check the box questionnaire? Do you feel safe at home? And what if that patient says no? Right. And I'm always curious, like what that would look like because it's like age, weight, do you feel safe at home, blood type? And it's just kind of like, okay. But thinking about whatever your role is and how you work with perinatal patients, if they were to disclose past or current trauma, what would you do? Do you feel comfortable, confident addressing it? Um, so something to think about. And then the other piece, which we won't have time for, and I spent the whole 30 seconds teeing it up, is Brene Brown, who's a social worker out of Texas. Sometimes we produce pretty solid people and things here in Texas. So Brene Brown, um, social worker here in our neck of the woods, and she has a really cool video about empathy. It's super short, what, 4 minutes, if that.
Yeah.
So you guys have some time this week. Check it out. It's a little cartoon, but it talks about empathy being connecting with another person. So, like Alexa said, our responsibility to be able to not only take care of ourselves, but that co-regulation piece is often the response isn't fixing it, right? It is being able to sit with that person and listen and know that what they are going through, what they went through was hard. And I'm here, right? And I'm here not to fix, but to be here and hold space with you. So, super cool video. We recommend you all checking out. So,
Um, oh,
go ahead. Go.
So what are some of those supportive responses? And this all may seem really simple, but again, if we kind of go back to polyvagal theory and that social engagement system where connection really is the medicine, connection is what we need to create safety. These are some of the things that we really encourage adding into your practice or continuing to utilize, which we're going to just make the assumption that you're all already doing this, right? So listening without judging, using validation, acknowledging, their fears, their desires, their wants, right? Using empathy and compassion, being collaborative, uh, offering reassurance and helping to create more control and safety for the survivor as much as you can in those spaces, offering to adapt care and make changes. So kind of like the example I gave of my OB-GYN and how she kind of adapted care to meet my needs. And then offering follow-up support. So knowing the resources in your community for any additional support that that person may need, which we're gonna talk about next, I think. Nope. We are going to talk about that. But this is a really simple, if you're not familiar with this, I mean, you can Google grounding techniques and 12 million things will be available. There's lots of options, but a grounding technique is anything that when you're in this flip lid state, it helps you become more embodied and more present and kind of bring that thinking brain back online. So if you are working with a client or a patient and you notice that they're here, that they're in that fight or flight mode, right? This is an easy tool that you could help guide them through, or even if you work with them prenatally, it could be a tool that you teach them to kind of take into their birth or postpartum spaces that they can use themselves. But it's 5, 4, 3, 2, 1, and it's engaging in the senses. So what are 5 things that you see, 4 things that you hear, 3 things you feel, 2 you smell, and 1 you taste. So that may look like you know, can you see me right in front of you? Do you see your partner next to you? Do you see your feet on the ground, right? Can you hear my voice? Can you hear the monitor? Do you feel the sheet over your legs? And then sometimes smell and taste can feel harder to access. So you can also talk about a calming smell or a calming taste if it's not actually a smell, a calming smell or taste like in the space. And you can utilize this. Sometimes you go through 4 things you see and you notice that there's been a shift, right? Sometimes you go all the way through 5, 4, 3, 2, 1, and they're still here, and you kind of have to do it a few more times, right? Or you have to jump ship and try a different grounding technique, right? So it's something that you can utilize as a provider to support clients in the moment. And it's something that you can also teach clients to utilize themselves internally in spaces. And then this is the part, you know, that offering those follow-up resources, really knowing and understanding what are the evidence-based therapies for trauma. There's quite a lot, so you don't just want to refer to any therapist. You do want to make sure that 1, they have knowledge and understanding of the perinatal period, and then 2, that they have knowledge and understanding of trauma recovery and offer different types of modalities to support that recovery. So some of the more common evidence-based therapies, this isn't all inclusive, are cognitive therapies such as CBT, CPT, that stands for cognitive behavioral therapy, cognitive processing therapy, and then ACT is acceptance and commitment therapy. There's EMDR or brain spotting, internal family systems, sand tray, somatic experiencing, yoga therapy, and also knowing other types of body work in your area that could be, you know, a comprehensive, that's not the right word. What's that called? Not comprehensive. Like they go together.
You're not asking me.
Okay, sorry. You're struggling with words today.
I'm
Whatever.
struggling with words.
Complimentary.
Accompanying?
Thank you.
Complimentary. Okay.
Complimentary. So other body work like pelvic floor therapy, acupuncture, massage, so on and so forth. We did learn when we were in Vermont, I think there's a really large, Kayla will have to tell you about it because I don't remember, but there was like a large perinatal specific resource that we learned about while we were there. So definitely connect to that if you don't know about it. And then this QR code will take you to our website. We have a resource list, not only that links you to a lot of the resources we kind of referenced as we were teaching today, but other resources that may feel helpful. We have books, websites, videos, like lots of different options, podcasts, I think, to explore. So, and then it also just takes you to our website if you want to learn more about what we're doing.
I was gonna say, if you guys are on your phones and if you don't have access to scan this QR code, you can go to our website. If you just Google Trauma Talk, or it's www.traumatalk.us, and it'll pop up. And then you also have, you know, access to us. So if you do have questions, you can definitely reach out. Our contact information is there, and then we also have a contact us page. So if there's anything that y'all need after, we're definitely here, especially when it comes to resources and additional learning. We'd love to kind of help and be a resource with that.
And we did it. We have time. We left time for questions. So we're happy to answer some questions now in the flesh.
Anything? Maybe no questions?
Oh, somebody's hand is raised. I don't know if that's on purpose. That might be an accident.
I feel like this might be the first time that we've done
There's
this,
no
and I haven't seen any
question.
questions.
Yeah, well, that's okay. I'm thankful for those of you that were here and listened, and you know where to find us.
Yes, and thank you both. Thank you, Alexis and Courtney. Thank you for this presentation today, as well as all the work you've done with our team. So thank you for that. And I also wanted to reiterate that today's training has been recorded, and that will be sent out as well as some information on the online modules that are forthcoming. And also wanted to put in a plug again for the trauma informed. Oh, my thing is blurred, but we have the badge buddies. So I'm going to add into the chat my email. So if anybody is interested, please reach out. We do have quite a few to distribute.
Can take us with you wherever you go.
Yes.
And yeah, we have the 3 C's, and then we also have the 5, 4, 3, 2, 1 on there as a reminder as well. So yeah.
All right. Thank you, everybody. And if
Awesome.
any other questions come up, feel free to reach out either to Kayla or myself, and we will pass those questions on to you too.
Sweet.
Thank you.
Thank you,
Thank
everyone.
you.